You asked me to talk about hysteroscopy, office hysteroscopy and fibroids. I know that most of you performed myomectomy in office, not in office, sorry, in OR with the resectoscope. And I want to show you different ways of doing the same. I don't have any conflict of interest in this case. So I want to take you to a voyage, to a trip, our way from now to the what I call the myomectomy planet. So we have to pass through different stations before we are ready to arrive to our planet. And the first one is to understand the myoma. We have to understand, we need to understand the anatomy, we need to understand the vascularity of the myoma. And something very important, we need to understand the cytocapsule, to know that it exists and to understand that. Regarding the anatomy, not all the myomas are the same. They are different. All of them, they have a matrix with collagen and other products, but they're completely different. If you see now the picture here, B, C, and also D, the structure of this fibroid, of this myoma is nodular. And then in E and F, you can see trabecular structure. And this is why you can find different consistency in the myoma, because there are different quantities of this extracellular matrix. You even can find, like in G and H, mixed patterns with both nodular and trabecular. So that's why we sometimes find that fibroids are very hard, and other times we can find myomas that are soft. This is one of the reasons. So now that we understand the structure, let's go to see the vascularity. There is no pedicle in a myoma, only if it's a G0 pedunculated myoma. There is a net of small blood vessels that surround the myoma. You can see it here when you see it on a Doppler color ultrasound. You see it like what we call a ring of fire surrounding the whole myoma. And these are very small blood vessels that surround the myoma and gives the myoma the food the myoma needs to grow. It comes from the surrounding. Important to understand that. And then we come to the most important part for me. It's to understand and to know what's the cytocapsule. So the cytocapsule is an area between the myometrium and the myoma. It's an anatomical plane that you can find there, full of many connective tissue bridges that they are very lax, very easy to open them, but all together they anchored the myoma there. I want you now all to think about a myomectomy by laparoscopy or an open myomectomy, in which you go, all of you go to find this plane and you dissect the myoma through this plane until you take the whole myoma out. The same here. You can find this cleavage plane and do a dissection. So right now we are going to see a small video in which you can see how easy it is to dissect and see this cleavage plane. So think about the myomectomy by laparoscopy or open myomectomy. So I hope you can see the video. We tried it before. Down there, you see I'm moving with the small grasper, I'm moving the myoma. So on the right side of the screen, you see the myoma. On the left side of the screen, the myometrium. And you can go through this area performing a dissection, separating the myoma. And it's easy to do as in laparoscopy if you find the right cleavage plane. Look here how easy it is to dissect and how we are breaking this small blood vessel and we are compromising the vascularity of the myoma. So the moment you do this, even if you don't finish, and you can see here the myoma is down there and the myometrium is behind, it's almost free. Even if you don't succeed doing it in one step because the myoma is big, when you come to the second step and you compromise the vascularity, this myoma will be small and will be wide and more easy to take it out. So now I want to go with you to the characteristics and types of the fibroids and why is it so important before we program our surgery. When we talk about hysteroscopy, we deal with those myomas that they are inside the cavity. G0, as you know, this is the figure classification, are the pedunculated, 100% of the myoma is inside the cavity. G1, most of the myoma is inside the cavity and small portion, less than 50% intramural. And G2, most of it intramural and a small part, less than 50% intracavitary. So this is a classification regarding where the myoma is. But if we go to step W classification of Ricardo Lasmar, it gives us, this classification gives us a score in order to know how difficult is it going to be the hysteroscopy myomectomy. And in this classification, he takes into account not only, like here, the grade of penetration of the myoma inside the cavity, but also the size in which wall the myoma is implanted. It takes many factors regarding the myoma. But I think that we always forget one factor that is very important when we go into this kind of surgery, is the size of the cavity. Look here. In both images, the myoma is the same size. But of course, in this big multiparous uterus, it's much more easy to perform the surgery because you have space in the cavity. And in the nulliparous uterus, you don't have enough space and you have more technical difficulties doing this kind of surgery. So this ratio factor, the ratio between the container and the contents, is something that's important in order to determine the success of the surgery. So how can we improve our results? How we can improve? So that's something we are going to see. What we can do is to try to reduce the myoma in order to improve the results. So let's go, how can we choose the right strategy, the right tools in order to perform office hysteroscopy myomectomy? So we have 4 different options: mechanical instruments that all of you know about them, tissue removal systems or morcellators, resectoscopy, that's the most known one. But when I talk about resectoscopy, I talk about the mini resectoscopy. And the use of energies like Versa point, it's the bipolar, or the use of lasers. So regarding mechanical instruments, it's only for the cases of small myomas. When you deal with graspers and scissors, you cannot deal with a big myoma. You will see that after that in a video that it's good, but only for small cases of myoma. That's the limitation of the mechanical instrument, but you can use it in small cases. Regarding tissue removal systems, the morcellators, depending on the consistency and the size, they're time consuming, because if the myoma is soft, you will remove it very quickly. But if the myoma, it's not so soft and it's big, it takes time. Of course, G1 also it takes time if it's a big one. And most of, we can say all of the tissue removal systems, they have a limitation, is the G2. G2 because it's very difficult for them to remove the endomural part of the myoma. Even this is the publicity of the MyoSure. Their own, I'm not bringing any study, just their own, and you can see here that in type 2 myomas, the percentage of tissue removed, it's 50%. That's because it's very hard to go inside the cavity. We have also studies like this one. It's a big one with 102 fibers, and the bigger the myoma is, the more difficult it is to remove the whole myoma, and all about they remove 66% of the tissue of the myomas. So we see also the limitations of the tissue removal systems. What about the mini resectoscope? For me, the mini resectoscope is the natural step going out from OR. Most of us, we started doing resectoscopy with bipolar or monopolar even years ago in OR. You know, we did dilation with Hagar, and we went with 8, 9 millimeters scope, and we performed resectoscopy using bipolar or monopolar energy. The mini resectoscope is 5 millimeters approximately, and you can perform exactly the same that you are used to do in OR, but this time in office. But remember, with this bipolar 9 millimeters to take 4 centimeters, 3 centimeter myomas, it takes 30 minutes, 60 minutes. It takes time with the big resectoscope. So imagine with this 4 millimeters resectoscope, it will take more time. So depend very much on the size of the myoma. It's, from my point of view, adapted for small myomas. And another thing that's important is when you use energy and you don't see where the energy is taking place, you can damage the myometrium. So if you are not used to do the enucleation to find this plane between the myoma and the myometrium, it's something it can happen with the mini stethoscope. And the last is the use of energy, and the use of energy for the enucleation of the myoma in hysteroscopy, the same like in laparoscopy. So you can use VersaPoint or laser, it doesn't matter. When you find a G0, you just make a small biopsy you need for histology, cut the pedicle, and you finish the procedure. You don't need to take the mass out. You just cut the pedicle and finish your procedure. I know there are going to be questions after that because of this polemic sentence I'm telling you, but that's all. When it's a G1, the enucleation, it can be performed, but for fibers that are less than 30 millimeters. But why is the 30 millimeters the limit? Because when the fiber is bigger than the cavity, you cannot enucleate it and put it inside the cavity. The same with G2, but with G2, often you need more than one step. As I told you before, if you want to perform enucleation, especially if they're a little bit big. So how did we arrive to this enucleation? This was my inspiration. Stefano Betocchi published in 2009, the opium technique. It's the preparation of partially intraoral myomas in office setting. What he did, as you can see in the picture, he uses the tweezle of the VersaPoint and he cut a crown around the myoma, cutting the mucosa and reaching the pseudocapsula. The natural behavior of the myoma is to migrate into the cavity, as you can see in the B picture, in the picture B. And he did the first step in office. And then he sent the patients to OR to perform the resectoscopy, as we all know. He did it with myoma with a mean size of 29 millimeters, they are not so small, and his success rate was of 93%. This was my inspiration because in our hospital in Barcelona, when we saw that, we decided that we have to try to do the 2 steps in office. And we did it, and we published it in 2013. We did it with fibroids G1, G2, not G0. And what we did is the enucleation. And these are the results. For fibroids until 18 millimeters, 100% of success. It's easy to do the enucleation. Those that are a little bit bigger, until 3 centimeters, it was an 85% of success rate, depending on the size of the cavity. But more than 3 centimeters, look, 0%, because the myoma was bigger than the cavity. So how can we improve the result? I think that we can improve the result by improving this factor, improving the relation between the cavity and what's inside the cavity, the container and the content. So which one of them we can change? The only one we can change is the fibroid. We cannot change the uterus. So how can we change the fiber? Maybe by reducing it. We have, in many countries in Europe, especially the ulipistol acetate, it's not allowed right now, but there are countries that they can use it, and the ulipistol acetate helps to reduce the myoma size. But look, Mark Emanuel published in 2015 this magnificent graph in which you can see the size of the myoma in centimeters, and on the left side you can see the minutes of OR resection. 3 centimeters, 30 minutes. 1 centimeter more, we go from 3 to 4 centimeters. It's 70 minutes, more than the double of time in 1 centimeter. So if we reduce even 1 centimeter, it doesn't matter the technique you are applying, you will reduce the time in OR, you will reduce anesthesia, you will reduce many factors for the patient. And in office, you will succeed doing the enucleation if you reduce the size of the myoma. That's why it's very important to find a way to reduce the myoma size. And now, this is the last step before we arrive to our planet, myomectomy planet, is to see the different kind of procedures. And we have different kind of procedures here. First, of course, we will try to do the tissue removal system. This is the MyoSure, 6.3 millimeters. And you see small fibers. I hope the video is quite good for you. And you see how fast with small fibers, and these are soft ones, the tissue removal system is the myoma. It's very easy. You just put the myoma near to the window of the tissue removal system, and the myoma slowly disappears into the system, and no more fibroid. This is another one, nice. You see again the removal. Quick, the learning curve of the tissue removal system is the easiest of all the learning curves in hysteroscopy. And now we go to a 5.1 millimeters mini receptoscope. Look at the fibroid. It's almost a type 3, not even a type 2. There's almost no distortion of the cavity. He's cutting the endometrium. Here's Dr. Ferro from the EV from Valencia, and he finds under the endometrium, he finds the myoma. But it was very difficult to see it in the cavity. And then look what he's doing. He's trying to find the Klieblatt's plane, this pseudocapsule. And he goes with the scope, with the loop to the pseudocapsule plane, and he starts cutting from the pseudocapsule towards us, respecting the pseudocapsule. And he's pushing, removing the myoma from removing the intramural part of the myoma, and the myoma slowly becomes intramural, even if it's so deep inside the wall. I like his technique. He is very clean, and he did it perfectly. Look, he's pushing and removing the myoma from the pseudocapsule. He's just disattaching it from the wall. Again, he will cut, and then he will.
Doctor, we have 2 minutes remaining.
It's the end. It's the video. It's then we finish. Then he's moving the intramural part. Look, disattaching it, and then I want you to see the fovea inside the cavity, inside the wall of the cavity of the uterus when he finished. This is the end. Now he will disattach it completely. He has to. And now you got it. So you see the fovea, and the fovea is respecting the myometrium. That's the important part of it, especially from the reproductive point of view. You respect the myometrium, no scars in the myometrium. This is very important. Now we are going to see the one you should start with. Small myoma performed by scissors, just as small myoma enucleation. This is performed, it was in office setting, no anesthesia. Look, the myoma is almost intramural. You see only the distortion of the cavity of it. It's a very small myoma. And first you start cutting the mucosa and looking for the Klieblatt's plane. I will try to move it a little bit forward. See, you try to find this Klieblatt's plane, and then when the moment you find it, you remove the myoma from the wall. And now it was very flat, and now you're going to see that the small white ball, that's the fiber that's inside the cavity. That's the way to do it. So find the Klieblatt's plane and remove it from the wall. And the last video, or the last part of the video, it's performed by laser. It was performed some years ago. The laser, the energy of the laser coagulates and cuts simultaneously. And the diffusion of the energy, it's 0.5 to 1 millimeter, so it's very safe. So what we are doing here, we're cutting and trying to find the Klieblatt's plane. Look here how it cuts and coagulates these blood vessels, and no bleeding at all, just coagulates and cuts. And what we do is just, we go and find the Klieblatt's plane. That's the next step. With a grasper. You don't need more than a grasper the moment you have it open. And you try here, no, it's not here. And then you try here, oh, it goes in. That's the right spot, the right place. And very easily, you can remove the fibroid. You can see it here. So that's the way to do it from my point of view, the enucleation in office in order to cleanly remove a fibroid from the wall, like in laparoscopy, myomectomy. So I think that we are ready to move and to arrive to our planet. So our conclusions in our planet are, first, hysteroscopy, office hysteroscopy myomectomy is something that it can be done. Second, start with small, get skill, and then go to big. Because if you try to remove at 3 centimeters at the beginning, you won't succeed. Try one with less 1 centimeter at the beginning. The best tool is the one you are skilled in the use of it. Don't try new ones and try or expect to get better results. You need to be skilled. There is no such a thing as a perfect device. There is no, all the devices are good. That's why we are using them. And I believe that the perfect strategy is to deal with the myoma is probably based in using more than one tool. Maybe resect the intramural part and then use a kind of cold loop to remove the intramural part, and of course, developing skills. And respecting the cell capsule by performance nucleation is considered for me the best approach today, especially from the reproductive point of view. So remember that every journey, it doesn't matter how long it is, it starts with a single step. Thank you very much.